Okay, let's unpack this. Every year, I mean, millions of patients walk into a clinic with what they just assume is a simple, albeit embarrassing plumbing issue.
Yeah, exactly. I think it's just a dietary thing.
Right. They assume the fix is just to eat more salad, maybe drink some water, or take an over-the-counter supplement. But if you are a colorectal surgeon or an advanced gastroenterologist or, you're preparing for your FRCS exams, you know that this symptom is just an absolute master of disguise.
Oh, it really is. It hides so much.
It hides absent nervous systems, it masks these paralyzing metabolic disorders, and it basically camouflages ticking surgical time bombs. We are, of course, talking about the clinical evaluation and management of severe constipation. And at this level, we have to look at the colon not as a passive pipe, but as this highly sophisticated, autonomically controlled neuromuscular transit system.
It really is the ultimate masquerader in gastrointestinal pathology. And for you, the listener, operating at a senior clinical or a PhD level, stakes here couldn't be higher. We're dealing with a massive epidemiological burden.
Yeah, it's huge.
In the United States alone, we are looking at a condition affecting roughly 15% of the population. Just to put that into perspective, I mean, a few years ago, we saw data showing nearly 6 million visits to healthcare professionals for constipation in a single year.
Wow. 6 million.
Right. But the true clinical challenge, it isn't the volume. It's the fact that misclassifying the underlying pathophysiology of this symptom leads directly to unnecessary morbidity. Or wildly inappropriate surgical interventions.
Or just entirely missed catastrophic diagnoses.
Exactly.
Right, because if a patient comes in and they have, say, a macroscopic, a ganglionic segmented bowel, or a minute receptor-level failure in the enteric nervous system, and we just tell them, to increase their dietary fiber, we are completely missing the boat.
Missing it entirely.
Sometimes we're missing an impending surgical emergency.
Exactly. So our mission today is to equip you with a really rigorous, granular breakdown. We're going to deconstruct the etiology, the advanced diagnostic modalities you need to utilize, and the specific pharmacological receptor targeting that acts as the bridge between medicine and surgery.
And finally, those complex operative interventions required when the colon essentially just becomes a dead organ.
Right. So if we are going to fix the engine, we have to understand exactly how it failed.
Right. So the sources divide the causes of constipation into 3 broad subtypes. We've got functional, chronic idiopathic, and secondary. Now, functional constipation is incredibly prevalent, right? Particularly in pediatrics.
Yeah, extremely common in kids.
But the defining hallmark of a purely functional diagnosis is the complete absence of an evident structural or organic cause. I mean, mechanically, the organs are completely intact.
They're intact, yeah, but the downstream effects are still devastating. We see massive secondary issues like fecal incontinence, behavioral problems. But again, there is no anatomical roadblock. Right. Chronic idiopathic constipation, or CIC, is in a really similar camp. It lacks a clear anatomical explanation, but we actually identify an underlying cause in fewer than 5% of these cases.
Which is wild.
It is. The real challenge for the surgical differential, though, lies in the primary functional failures. So that's normal transit constipation, slow transit constipation, and pelvic floor dysfunction.
Okay, let's pull these apart, maybe starting with slow transit constipation, or STC. Because the hallmark here isn't just that the patient has infrequent bowel movements, it's that the actual urgency, like the neurological signal that it's time to evacuate, is profoundly diminished.
Yes, and the mechanical failure here is really fascinating. STC is defined by impaired phasic colonic motor activity.
Okay, break that down for us.
So to understand this at a functional level, we have to look at the colon's intrinsic motility engine. The colon relies on high-amplitude propagated contractions to move the fecal mass forward.
Right, the propulsive waves.
Exactly. In STC, the colon simply fails to generate these propulsive waves. We're often looking at a disruption at the level of the interstitial cells of Cajal.
Which are basically the pacemakers of the gut.
Right, the pacemakers. Or we're looking at a dysfunction within the myenteric plexus itself. So the hardware is there, but the engine is essentially stalled.
Okay, contrast that with pelvic floor dysfunction, because in these patients, the transit time from the ascending colon all the way to the rectum might be perfectly normal.
Right, the engine works perfectly fine.
But the musculature of the pelvic floor is impaired.
Right.
They cannot coordinate that really complex paradoxical relaxation of the puborectalis muscle and the external anal sphincter that's actually required for evacuation.
Precisely. And this presents with very specific clinical markers. These patients will report a constant feeling of incomplete evacuation or prolonged agonizing straining.
Right.
And crucially, they often resort to perineal or vaginal pressure. They are physically, mechanically trying to compensate for a localized muscular failure right at the outlet.
Okay, so STC is an engine failure, and pelvic floor dysfunction is basically a door that won't open. But here is where it gets incredibly paradoxical to me.
Normal transit constipation.
Yes, NTC. Imagine a train that arrives at the station perfectly on time every single day, but the doors simply refuse to open and the passengers just can't get off. If the transit of the stool through the colon is at a completely normal rate, why is the patient still physically unable to evacuate?
It's a great question.
Like, is this purely a sensory failure at the terminal end, or is there some microscopic mismatch in the evacuation mechanics?
It's the exact paradox that frustrates literally everyone involved.
Yeah.
In NTC, the macro mechanism of colonic transit is working beautifully. The stool reaches the rectum perfectly on schedule,
Right.
but the process breaks down right at the exit. And it isn't always as gross or obvious as your classic pelvic floor dyssynergia. Often it's just a really subtle sensory deficit.
So the rectum fills up, but the body just doesn't know it.
Exactly. The wall distends, but that mechanical stretch fails to trigger the proper efferent urge. Or it's a microscopic discoordination of the anal sphincters that falls just under the threshold of what we can easily detect on a basic exam.
And if you're listening to this and thinking about your surgical decision-making, I mean, this is exactly why identifying the exact point of mechanical failure is so vital.
Oh, absolutely.
Because if you evaluate a patient with normal transit constipation and you decide, hey, let's perform a total abdominal colectomy, well, you've just subjected that patient to a massive life-altering operation, and you haven't even fixed the problem.
You haven't touched the problem.
Right. The terminal evacuation failure, which is the real issue, is still sitting right there.
It is a devastating surgical error. You've removed a perfectly functioning transit system to try and fix an outlet problem. This is exactly why the surgical differential diagnosis is so unforgiving at this level.
And why it leans so heavily on identifying the secondary causes of constipation.
Right. The sources provide this vast array of anatomic, muscular, and neurologic etiologies that we just have to map out meticulously.
Let's dive into those structural anatomic blocks, because we are talking about physical barricades where absolutely no amount of colonic pushing is going to help.
Right. Physical roadblocks.
Things like anal stenosis, anal atresia, an anteriorly displaced anus, or an imperforate anus. These are absolute structural failures, often congenital, where the plumbing is just physically misrouted or entirely blocked.
And then you have acquired structural blocks, too. Think about a patient with severe anal fissures who develops a reflex withholding behavior.
Because the pain of defecation is just so severe.
Exactly. They hold it in to avoid the pain. Or you have obstructing tumors, thrombosed hemorrhoids, and intestinal strictures. If there's a physical mass occluding the lumen, your physiological transit time is completely irrelevant.
But it actually goes beyond just the tube itself. We also have to look at the surrounding abnormal musculature, conditions like prune belly syndrome, gastroschisis, Down syndrome, and even muscular dystrophy.
Yeah, the external muscles.
Right, and this is where the actual physics of defecation becomes so important. We all know that evacuation requires an increase in intra-abdominal pressure. But if a patient has prune belly syndrome, they literally lack the abdominal wall musculature to generate that pressure.
It highlights beautifully how defecation is a whole body mechanical process. The intrinsic colonic motility might be flawless, right? The pelvic floor might even relax on command.
But without the push.
Without the push, without that external mechanical compressive force from the abdominal cavity, the whole system fails. Evacuation simply cannot occur.
And even more complex than the gross musculature are the neurologic causes. This is where we see disorders that are literally destroying the intrinsic neurological structure of the intestine itself.
Right.
The classic, highly tested example here is Hirschsprung disease. We often summarize it as in a ganglionic segment of bowel, but the pathophysiology is what's truly fascinating here. It's actually a failure of neural crest cell migration.
Exactly. And the critical point to understand for advanced practice is why the ganglionic segment actually causes an obstruction.
Right, because it's not just a floppy, dead piece of bowel, is it?
Not at all. The absence of the myenteric and submucosal plexuses means there is an absence of the inhibitory neurons. And specifically, we're talking about the ones utilizing nitric oxide and vasoactive intestinal peptide.
Okay, the VIP.
Right. Without those inhibitory signals to tell the smooth muscle to relax, the intrinsic cholinergic tone just goes completely unopposed.
So the bowel is basically locked in a state of sustained tonic contraction. It acts as this rigid functional stricture.
Precisely. And everything proximal to that stricture just dilates massively as the normal bowel tries to desperately push stool through a segment that simply refuses to relax.
Wow.
But Hirschsprung is just one piece of the puzzle. The sources also point to intestinal neuronal dysplasia, spinal cord defects, tethered cord, and then your systemic neurological disorders like stroke, multiple sclerosis, and Parkinson's disease.
The sources specifically mention Chagas disease, too, which is a brilliant illustration of acquired neurological destruction.
Oh, absolutely.
Because the American trypanosomiasis parasite, Trypanosoma cruzi, it physically invades and destroys the myenteric plexus. It is an infectious obliteration of the enteric nervous system, leading directly to megacolon.
It's terrifying. And we also cannot ignore the metabolic, endocrine, and pharmacological drivers. Think about this at the cellular level. Hypokalemia and hypercalcemia. We all know these electrolyte derangements cause constipation, but do we know how?
Right. What's the actual mechanism?
Hypercalcemia, for instance, alters the threshold for the action potential in colonic smooth muscle. It effectively hyperpolarizes the membrane, making it significantly harder for the muscle to depolarize and contract.
Okay, so the muscle is structurally fine and the nerves are fine.
But the electrical environment is hostile to peristalsis.
That makes perfect sense. And hypothyroidism slows the global metabolic rate, which includes the slow waves of gut motility. Diabetes mellitus induces an autonomic neuropathy that blunts the enteric signaling.
Yeah. And the pharmacological list is an absolute nightmare. You've got anticholinergics drying up secretions, narcotics paralyzing motility, calcium channel blockers doing exactly what you just discussed with hypercalcemia, plus antidepressants and even intoxications with lead, iron, bismuth, or vitamin D.
It is a really delicate, easily disrupted ecosystem.
So we've mapped the failures. We understand the intrinsic engine, the muscular outlet, the neurological wiring, and the metabolic environment. But the true test for the advanced clinician isn't just knowing the taxonomy, right?
No, not at all.
It's knowing how to extract this information from a patient who is often embarrassed, or they're adapting to their dysfunction, or they're just entirely unaware of the severity of their condition. Which brings us to the clinical evaluation and the search for the critical alarm signs. The clinical evaluation is the absolute crucible. It is where you either set the patient on the correct diagnostic pathway or you completely miss a life-threatening pathology. And the sources are incredibly explicit here, okay? The diagnosis of constipation should never, ever rely simply on asking the patient, are you constipated?
Right. It's a completely subjective, frankly useless question at this level. The text notes that this limited inquiry is associated with massive underreporting.
Exactly.
You can have a patient with glaring physical evidence of chronic constipation, like severe hemorrhoidal disease or rectal prolapse, who will literally look you in the eye and say, no, I'm not constipated.
Because patients normalize their dysfunction. The human body, and honestly the human mind, just adapts. If a patient has had a bowel movement every 4 or 5 days for the last decade, well, that is their normal.
They don't perceive it as pathology at all.
Right. Therefore, the clinician must conduct a highly structured, almost forensic audit of their habits. You cannot accept vague answers. You must define the exact frequency of their altered patterns.
You have to establish a real baseline.
You have to ask, how does this current pattern compare to your usual pattern?
Yeah.
You need to inquire specifically about the perceived hardness of the stools, ideally using something like the Bristol stool scale.
And you really have to push into the uncomfortable behavioral compensations. Are they relying on digital extraction?
Right.
Are they using water enemas daily just to function? Are they experiencing extreme tenesmus? You know, that agonizing feeling that they constantly need to pass stool, even when the vault is totally empty.
Those are massive clues.
Right, because these behavioral clues are the giant red flags pointing directly toward pelvic floor dysfunction or a severe outlet obstruction. But beyond defining the mechanics of the constipation, the history is a targeted hunt for alarm features. These are the red flags that mandate immediate aggressive escalation.
This is the dividing line between chronic functional constipation and an impending surgical crisis or an undiagnosed malignancy. We are looking for rectal bleeding. We are looking for unexplained rapid weight loss, an abrupt loss of appetite, a family history of gastrointestinal malignancy. And for the surgeon, perhaps the most terrifying alarm sign of all, the absolute inability to pass flatus.
Because if a patient cannot pass flatus, we are no longer dealing with constipation. We have crossed the threshold into a complete mechanical bowel obstruction.
Exactly. If gas cannot navigate the lumen, absolutely nothing else is getting through. That is an acute, rigid abdomen waiting to happen.
Now, if we shift our focus to the pediatric evaluation for a second, the parameters for the alarm signs change, but the urgency remains identical, doesn't it?
Yes. In an infant, the history must rigorously detail the exact timing of the first bowel movement after birth. Failure to pass meconium in the first 24 to 48 hours is just a blaring siren for a congenital anomaly.
And the sources highlight a specific pediatric alarm sign that always feels incredibly paradoxical to the untrained eye: bloody diarrhea in an infant with a history of constipation. Now, diarrhea seems like the exact opposite of constipation. But to a pediatric surgeon, bloody diarrhea in this setting is a textbook, chilling indicator of Hirschsprung-associated enterocolitis, or HAEC.
It is a brilliant example of why we have to understand the underlying pathophysiology. In HAEC, you have a ganglionic contracted segment of bowel. The stool impacts proximally. This causes massive upstream dilation and severe stasis.
Which is just a breeding ground for bacteria.
Exactly. That stasis becomes a breeding ground for bacterial overgrowth. And then the distension compromises the microvascular blood flow to the colonic mucosa, leading to ischemia.
Oh, wow.
The combination of bacterial invasion and ischemic mucosa results in an explosive, paradoxical, bloody inflammatory diarrhea. It is a life-threatening complication that requires immediate decompression, not just a simple laxative.
That perfectly illustrates why the physical and rectal examination must be executed with absolute precision. You don't just palpate the abdomen, right? You're looking at their overall nutritional status.
Yeah.
You're assessing for gross distension, localized tenderness, and palpable masses that might indicate a tumor or a massive fecalith. And you are listening, really listening, to the bowel sounds. High-pitched, tinkling bowel sounds suggest the bowel is desperately fighting against a mechanical obstruction.
Right.
Whereas absent bowel sounds suggest a paralytic ileus, or that the colonic inertia is so profound the engine has completely quit.
And then we move to the rectal examination. This is where the forensic audit gets physical. You are inspecting the perianal area for fissures that might be causing reflex withholding. You're evaluating for hemorrhoids, active inflammation, or the presence of a rectal prolapse.
Checking all the hardware.
Checking the hardware.
Yeah.
You're assessing the resting sphincter tone to rule out gross neurological deficits. And crucially, you're performing a digital sweep to feel for hard, impacted stool right there in the rectal ampulla.
But if you are the surgeon on call, sometimes the absence of crews is far more terrifying than finding a mass. If you evaluate a patient presenting with acute, severe constipation and they have massive abdominal distension, they look like they're 9 months pregnant.
Yeah.
And you perform a digital rectal exam and find an entirely empty rectal vault, that is a chilling moment. Because a novice might think, well, if it's full of rock-hard stool, isn't that worse? No.
Not at all. An empty vault in the setting of massive distension is the hallmark of a higher-level proximal obstruction. The colon is dilated, but the roadblock is so high up that the stool isn't even making it to the terminal exit. The rectum is collapsed and empty.
It's completely starved of content.
Right. That single physical finding dictates a completely different, much more urgent trajectory for the diagnostic workup.
And I should add, for the cases that don't have these blaring alarm signs, the purely functional diagnoses, the sources note the utility of the Rome-Fork criteria for both adults and pediatrics. It just helps standardize the diagnosis of functional constipation, ensuring we're all speaking the same clinical language once the organic, terrifying pathologies have been definitively ruled out.
But let's say the clinical exam has raised our suspicion. Or say we have a refractory case that has completely failed 3 to 6 months of basic, aggressive medical management. The patient is suffering, the osmotic laxatives aren't working, and we need to see the invisible forces at play.
We have to map it.
We must move beyond the bedside and utilize the advanced diagnostic modalities.
So we are staring at an empty rectal vault, the abdomen is rigid, or the patient has just failed their 3rd trial of PEG. What is our next move? The sources note that laboratory investigations don't play a massive role in the initial evaluation of simple constipation, but for the refractory patient, we absolutely have to rule out systemic drivers.
We do. We run a complete blood count, a CBC. We're looking for anemia, which could be the only subtle indicator of chronic microscopic mucosal blood loss from a hidden right-sided colorectal cancer.
Right.
Or we might see an elevated white count pointing to an underlying ileus, localized ischemia, or early intra-abdominal sepsis. We check the TSH to definitively rule out hypothyroidism.
Because if the thyroid is failing, no amount of targeted gut therapy will overcome that global metabolic slowing.
Exactly. And we run a comprehensive metabolic panel to hunt for those contractility-killing electrolyte derangements we discussed earlier, like hypokalemia and hypercalcemia.
But the real escalation is radiological. In patients with symptoms suggesting systemic or intra-abdominal pathology, plain films are really the first step. We need an upright chest radiograph to check for free air under the diaphragm, which is, of course, the hallmark of a perforation.
Right.
And a flat and upright abdominal X-ray. And what are we really looking for on that abdominal film? We're trying to differentiate mere widespread fecal loading from a true mechanical bowel obstruction, a massive fecal impaction, or the presence of a fecalith.
The fecalith is a critical concept here. A fecalith isn't just a hard piece of stool. It is a dense, rock-like, calcified concretion of feces.
It's literally a stone.
It is essentially a stone sitting right there in the colon. And missing a fecalith on an abdominal film can lead directly to stercoral ulcers.
Let's break down the mechanics of a stercoral ulcer, because this is where the physics of the colon turn deadly. You have this rock-hard fecalith lodged in the colon, usually in the sigmoid or rectum, where the stool is the most desiccated. The colon wall is constantly contracting, right? It's trying to push it forward.
Yeah, but it won't move.
It won't move. So you have constant, unyielding mechanical pressure of this stone against the delicate colonic mucosa.
And that localized pressure exceeds the capillary perfusion pressure of the bowel wall. The mucosa just becomes ischemic. It ulcerates.
Wow.
And if the pressure isn't relieved, that ischemia progresses through the submucosa, the muscularis, and eventually the serosa. The colon wall dies and gives way. That is a stercoral perforation.
And a stercoral perforation is a catastrophic surgical emergency. You are suddenly dumping heavily colonized rock-hard feces directly into the sterile peritoneal cavity of an often frail, elderly patient.
It causes a massive feculent peritonitis.
Right, the mortality rate is staggering. So identifying that fecal loading versus a true fecalith on the plain film is literally a matter of life and death.
Absolutely. And if that abdominal film or subsequent CT scan shows acute constipation with an empty rectal vault but a massively dilated proximal colon filled with air or stool, indicating a large bowel obstruction, we have to map the exact site of the roadblock.
How do we do that?
The sources indicate the use of a gastrograph and enema, which is water-soluble and safer if there is a microperforation. Or we use lower gastrointestinal endoscopy to visualize the exact nature of the obstruction. We need to know, is it a tumor? Is it a stricture? Is it a volvulus?
But let's look at the other scenario. There is no gross obstruction. There's no tumor, no stricture, no fecalith. The colon just simply isn't working. This is where we elevate to the PhD level of physiological testing.
Right, we have to measure the function.
We have to measure the pressures, the transit times, and the reflexes of the gut. Let's start with anorectal manometry.
Anorectal manometry is a brilliant tool. It's designed to evaluate both the motor and sensory function of the anorectum. We insert a pressure-sensitive catheter right into the rectum. One of the primary reflexes we are testing is the rectoanal inhibitory reflex, or the ARR.
Let's unpack the ARR because the physiology here is so elegant. Under normal circumstances, when the rectum distends with stool, or in the case of the manometry test, when we inflate a small balloon, it triggers a reflex arc.
Yes.
The intrinsic enteric nervous system releases vasoactive intestinal peptide and nitric oxide, which causes the smooth muscle of the internal anal sphincter to involuntarily relax. This allows the stool to descend into the anal canal, where it meets the striated, voluntarily controlled external anal sphincter.
That is the perfect normal physiological sequence. But in Hirschsprung disease, because that critical ganglionic segment completely lacks the myenteric plexus, it cannot release those inhibitory neurotransmitters.
So no VIP, no nitric oxide.
Exactly. Therefore, when you inflate the balloon in the rectum, the internal anal sphincter simply does not relax. The ARR is absent. Manometry is highly sensitive for flagging this failure.
However, the sources are very explicit about this next point, and this is a classic FRCS trap. While manometry aids significantly in the diagnosis, a rectal suction biopsy remains the absolute undisputed gold standard for diagnosing Hirschsprung disease.
Absolutely.
You must have definitive histologic proof under a microscope demonstrating the complete absence of ganglion cells in the submucosal plexus. You cannot resect a child's colon based solely on a pressure tracing.
Correct. Tissue is the issue. Now, moving proximally from the anorectum, we have colonic manometry. This is a much more invasive test.
Yep.
It involves the colonoscopic insertion of a specialized catheter throughout the entire length of the colon to measure segmental pressures over an extended period.
This sounds like we are directly mechanically testing that phasic colonic motor activity we talked about earlier when we were defining slow transit constipation. We are basically looking for the engine's pulse.
Exactly. We are mapping the colonic pressure waves. This diagnostic modality is crucial for differentiating between neurogenic and myogenic causes of severe constipation.
How does that work?
Well, we can administer stimulants through the catheter.
Mm.
If the muscle responds and contracts, we know the muscle itself, the myogenic component, is viable. But the native nerve signaling, the neurogenic component, is failing.
Oh, I see.
If we stimulate it and nothing happens, well, the muscle itself is diseased.
Mm.
However, the text notes a frustrating caveat. There is no single specific motility pattern that is perfectly, universally diagnostic of idiopathic constipation. The physiological waters still remain a bit muddy.
So, to complement those stationary pressure readings, we need to actually see the transit speed. We need to track the cargo. That is where colonic transit studies come into play. The patient swallows a capsule containing small radiopic markers, and we take serial abdominal x-rays over several days, usually day 3 and day 5.
Right.
This allows us to physically map the anatomical sites of fecal retention.
It is a beautifully simple but highly effective test. If you take an x-ray on day 5, and all the markers are still scattered randomly throughout the entire ascending, transverse, and descending colon, you've confirmed severe colonic inertia.
The engine is dead.
The engine is dead. You have slow transit constipation. But if you take that x-ray on day 5 and all the markers have successfully traveled the entire length of the colon and are gathered together, sitting in the rectus sigmoid just waiting to exit but they cannot be expelled, you have a terminal outlet obstruction.
Which is pelvic floor dysfunction.
Or normal transit constipation with an evacuation failure.
And if those transit markers tell us the roadblock is specifically at the level of the anal canal, the final advanced test we deploy is defecography. I find defecography to be one of the most mechanically revealing tests in all of surgery. We aren't just looking at static anatomy, we're watching the architecture function or fail under stress.
The technique is incredibly revealing. We fill the rectus sigmoid with a thick barium paste that mimics the exact physical consistency of stool. Then, the patient sits on a radiolucent commode, and we observe them fluoroscopically while they actively attempt to defecate. We are watching the mechanics in real time.
It is unparalleled for dynamic visualization. You can measure the changes in the anorectal angle. You can witness a transient rectal prolapse that completely reduces and vanishes the moment the patient stands up. That's a structural failure you would completely miss on a static physical exam while the patient is lying on their side.
Yeah, you'd never see it.
You can see internal intussusception, where the rectal wall literally folds in on itself, telescoping downward to act as a one-way biological valve that physically blocks the exit. Or you can see profound pelvic floor weakness, where the perineum simply descends abnormally during the active strain of defecation.
So we have built a comprehensive diagnostic profile. We used anorectal manometry to measure the terminal reflexes. We used colonic manometry to measure the intrinsic pressure waves. We used transit studies to track the speed of the cargo. And we used defecography to watch the anatomical architecture fail dynamically.
We've mapped the precise location and mechanism of the failure.
Right. But before a surgeon ever considers picking up a scalpel, we must exhaust the medical options. And at this level of pathology, when a patient has failed 3 to 6 months of basic management, we are not talking about recommending an apple a day or telling them to drink more water.
No, we are entering the realm of pharmacological escalation and receptor-level interventions.
The threshold here is severe. We have moved far past basic dietary fiber. In the pediatric population, the sources note that laxatives are the first-line treatment, and specifically, the consensus guidelines rely heavily on daily polyethylene glycol, or PEG.
Let's look at the pediatric dosing for PEG, because if you are looking at these guidelines, the intervention is really aggressive. For initial fecal disimpaction in a child, the guidelines call for 1 to 1.5 grams per kilogram per day for 3 to 6 days. Think about that volume. If I'm a clinician, I'm thinking 1.5 grams per kilo seems incredibly aggressive. Are we not worried about massive electrolyte shifts at that volume?
That is exactly the beauty of PEG. It is a long-chain polymer that is non-absorbable and osmotically active. It pulls water into the lumen to soften the stool, but it does not cause the severe fluid and electrolyte shifts associated with older osmotic agents, like high-dose magnesium or phosphate enemas.
So it's safer.
It is safe, but it requires that high dose to break the mechanical impaction. Following disimpaction, the maintenance dose drops to 0.4 grams per kilogram per day for at least 2 months. That's to prevent the rectal vault from re-expanding and reaccumulating stool.
And if PEG alone doesn't cause disimpaction after 2 weeks, the guidelines mandate the addition of a stimulant laxative.
Right.
But what happens when osmotic agents like PEG, bulk-forming agents, emollients, and rapid lubricants completely fail in the adult chronic idiopathic constipation population? The transit studies show the markers aren't moving. The colon is sluggish. This is where we bring in the heavy-hitting prescription therapeutics. We are looking at specific, targeted pharmacodynamics. Let's start with lubiprostone.
Lubiprostone is a fascinating molecule. It is a bicyclic fatty acid derived from prostaglandin E1, but its mechanism of action is highly specific. It acts directly as a chloride channel activator.
If we think about this mechanistically, it's essentially a chemical floodgate. You aren't pushing the stool with the stimulant. You are hacking the cellular walls of the colon to open the fire hydrants and flood the lumen with water.
That is exactly what is happening. By activating the type 2 chloride channels, the CLC2 channels, on the apical membrane of the gastrointestinal epithelium, lubiprostone forces chloride ions out of the cell and into the intestinal lumen.
Okay.
Because of the electrochemical gradient, sodium passively follows the chloride, and where sodium goes, water follows to maintain osmotic neutrality. The result is a massive, targeted increase in intestinal fluid secretion.
Which softens the stool and accelerates the transit.
Right. It is FDA approved for chronic idiopathic constipation at a dose of 24 micrograms twice daily.
But the contraindications are vital for the advanced clinician to remember. Because it rapidly increases luminal fluid and accelerates transit, lubiprostone is absolutely contraindicated in patients with a known or suspected mechanical gastrointestinal obstruction.
That is a massive red flag.
Yeah. If you flood a pipe that is physically blocked by a tumor, an unyielding stricture, or a massive fecalith, the pressure will build rapidly behind the obstruction. You are begging for a blowout. You are begging for a perforation.
Absolutely.
Also, from a patient tolerance perspective, nausea is a significant dose-dependent adverse effect, which is mitigated by taking it with food, and it requires careful dose reduction in patients with hepatic insufficiency.
Moving to another class, we have the guanylate cyclase C agonists, linaclotide and plecanatide.
So we've talked about chloride channels. What does this class mean for the cellular environment of the gut? Are we again hacking the cellular pathways to force transit when the native nervous system has given up?
Yes, but through a totally different receptor. We are bypassing the broken macromechanisms, the failed peristalsis or the sluggish transit, by manipulating localized cellular secretion via cyclic GMP pathways.
Okay, walk us through that.
When linaclotide or plecanatide binds to the guanylate cyclase C receptor on the luminal surface of the intestinal epithelium, it triggers an increase in both intracellular and extracellular cyclic GMP. This elevation in cGMP is the key.
Right.
It stimulates the cystic fibrosis transmembrane conductance regulator, or CFTR, chloride channel. This leads to a profound increase in luminal chloride and bicarbonate secretion,
Which again draws massive amounts of water into the lumen and accelerates transit. Linaclotide is given at 72 or 145 micrograms daily, usually taken at least 30 minutes before the first meal. Plecanatide is similar, given at 3 milligrams daily. But if you were listening to this and wondering why choose plecanatide over linaclotide, the sources highlight a unique structural difference. Plecanatide is pH-dependent in its binding.
It is a nuanced but really important pharmacokinetic distinction. Plecanatide's structure allows it to be active primarily in the pH environment of the proximal small intestine, mimicking the body's native uroguanylin, whereas linaclotide acts throughout the GI tract. But clinically, they share the same major warnings. Like lubiprostone, these are absolutely contraindicated in mechanical GI obstruction. And severe diarrhea is the primary adverse effect that might force discontinuation of the therapy. You are opening the floodgates, and sometimes it just works too well.
And then we have a fundamentally different mechanism with precalopride. While lubiprostone and the guanylate cyclase C agonists alter fluid dynamics to basically wash the stool out, precalopride is a highly selective serotonin 5-HT4 receptor agonist.
It targets the nervous system of the gut directly.
Exactly. We are no longer just adding water, we are trying to chemically jumpstart the engine.
By stimulating the 5-HT4 receptors located directly on the enteric neurons, precalopride facilitates the release of acetylcholine. This essentially forces the colon to contract. It induces and increases the amplitude of those colonic high-amplitude propagated contractions.
The exact mechanical propulsive waves that we noted were failing in slow transit constipation.
Right. It chemically bypasses the sluggish native pacemaker to increase bowel movement frequency. The recommended dose is 2 milligrams once daily, which must be adjusted to 1 milligram in patients with significant renal impairment.
The contraindications for prucalopride are severe. They are incredibly logical if you understand the mechanism, and they are heavily tested. Because it forces powerful, high-amplitude colonic contractions, you absolutely cannot use it in patients with a Crohn's disease, ulcerative colitis, toxic megacolon, or any intestinal perforation or obstruction.
Oh, that would be terrible.
Forcing a massive, chemically induced contraction against an inflamed, friable, or physically blocked bowel wall is catastrophic. It will cause a perforation.
Finally, within this advanced pharmacological arsenal, we really must address a very specific secondary cause: opioid-induced constipation. Opioids bind heavily to the mu-opiate receptors in the gut. This binding paralyzes motility, decreases secretions, and increases sphincter tone.
It's a perfect storm.
It is a perfect storm for severe constipation. When conventional laxatives fail in these patients, we deploy peripheral mu-opiate antagonists like methylnaltrexone, naldomidine, and naloxone.
The biochemistry of these drugs is brilliant. They are structurally designed, often by adding a methyl group, to ensure they cannot cross the blood-brain barrier.
Right, they stay in the periphery.
Exactly. They selectively block the opiate receptors in the gut, effectively restoring motility and secretion without reversing the central analgesic effects of the patient's pain medication in the brain. They provide a vital pharmacological bridge to keep the gut moving in patients who are deeply dependent on narcotics for pain control.
But here is the harsh reality of clinical practice. Despite our best efforts with PEG, chloride channel activators, guanylate cyclase agonists, and 5-HT4 stimulation, well, there is a subset of patients for whom medical management completely and utterly fails.
Yeah.
The cellular receptors simply do not respond, or the structural anatomy mapped on the defecography is fundamentally incompatible with evacuation.
Which brings us to the final frontier. When hacking the receptors isn't enough, the scalpel is the final option. And the threshold for surgery isn't as rare as one might hope. The sources highlight an incredible statistic. At least 10% of children with functional constipation referred to a pediatric surgeon will eventually require some form of operative intervention.
10%.
The overarching goal is always symptom alleviation and restoring quality of life. But the surgical techniques vary wildly based on the exact pathophysiology we mapped during the diagnostic phase.
Let's look at the definitive nuclear option for severe colonic inertia, or slow transit constipation that has completely failed all medical management. The surgical option here is the total abdominal colectomy with ileorectal anastomosis.
It is a massive, irreversible undertaking. You are essentially admitting that the entire colon is a dead, useless organ.
That's right.
The surgeon enters the abdomen, resects the entire abdominal colon from the cecum all the way down to the rectosigmoid junction, and physically attaches the terminal ileum directly to the rectum. You eliminate the transit delay by completely eliminating the transit pathway.
It is highly effective for pure colonic inertia. But remember our earlier discussion on normal transit constipation and pelvic floor dysfunction. Patient selection here is paramount.
Oh, absolutely.
If you perform a total abdominal colectomy on a patient whose primary underlying issue is an inability to relax the pelvic floor, which is a structural outlet obstruction, you have doomed them to failure.
It would be an absolute disaster. They would now have high-volume liquid ileal contents constantly reaching your rectum that still cannot mechanically evacuate.
Right.
You've traded severe constipation for severe, agonizing, unmanageable incontinence or a constant feeling of rectal fullness. This is precisely why the diagnostic workup, the transit studies to prove it, is slow transit, and the manometry to prove the pelvic floor actually works is completely non-negotiable before offering a colectomy.
For patients with pelvic floor and outlet obstruction issues, the surgical approaches are entirely different. We are not removing the transit pathway. We are trying to fix the broken door. We're looking at managing benign outlet obstruction and prolapse. The sources mention the stapled transanal rectal resection, or STAR procedure, and anapexy.
Let's break down the STAR procedure because it perfectly addresses the anatomical failures we saw on defecography. If the defecography shows a profound internal intussusception, the bowel telescoping in on itself, or a massive rectocele where the anterior rectal wall bulges into the vagina, trapping a pocket of stool that just cannot be evacuated, well, the STAR procedure is a transanal approach to fix it.
Right.
A circular stapler is introduced directly through the anus to circumferentially excise that redundant, obstructing rectal mucosa and staple the wall back together. It pulls the slack out of the wall, restoring a straight, functional anatomical cylinder.
It basically corrects the physical trap. Laparoscopic ventral rectopexy is another powerful option advocated for this problem. It is significantly more invasive, involving entering the abdomen laparoscopically, mobilizing the rectum, and using a biologic or synthetic mesh to physically hitch the anterior rectum up to the sacral promontory.
Wow, so physically lifting it.
Yes, hitching it up. But it is highly effective at correcting the anatomical prolapse that is causing the mechanical outlet obstruction.
But what about patients where the gross anatomy is fine, the colon isn't completely dead, but the nerve signaling is severely refractory, and we desperately want to avoid a total abdominal colectomy? We are looking for a middle ground. This is where neuromodulation comes in, specifically sacral nerve stimulation.
Sacral nerve stimulation, or SNS, is a fascinating modality that bridges physiology and surgery. It involves surgically implanting an electrode directly through the sacral foramina, usually at the S3 nerve root. This electrode is connected to a subcutaneous pulse generator, essentially a pacemaker, to continuously modulate the extrinsic neural control of the large bowel, the pelvic floor, and those complex inhibitory reflexes.
We are essentially installing a synthetic tastemaker for the pelvis. We are trying to electronically hack the precise autonomic signaling that we previously tried to hack chemically with prucalopride.
Exactly. The sources note it has improved defecation frequency in some children with severe functional constipation. However, there is a significant clinical caveat noted. In a large group of patients, the beneficial effects were actually found to last less than 6 months.
Oh, wow.
It highlights that while the theory is sound, we are still trying to perfect the long-term electroneural control of the gut.
It is an evolving science. And while we strive for these elegant neuromodulation solutions, we must also discuss the disastrous endpoints that surgeons are often forced to manage when constipation is unrecognized, ignored by the patient, or inadequately treated. These are the severe complications that arrive in the emergency department at 2 a.m.
The complications of unmanaged constipation are the absolute nightmare scenarios of the general surgery on-call shift. We detailed stricoral perforation earlier, the focal pressure necrosis from a dense fecalith leading to a catastrophic blowout of the colon wall, and feculent peritonitis. But there's also volvulus.
Volvulus is a terrifying mechanical failure. A chronically constipated, massively dilated sigmoid colon, heavy with pounds of retained stool, elongates over time. It becomes a massive, floppy, redundant loop of bowel on a really narrow mesenteric pedicle.
Yeah.
And because it is so heavy and redundant, it can easily twist on its own mesenteric axis.
Like twisting a balloon animal. And when it twists, it immediately cuts off its own blood supply. It is a closed-loop obstruction combined with rapid strangulation and ischemia. If not immediately decompressed endoscopically or resected surgically, that segment of colon will absolutely die and perforate.
And the chronic, daily, agonizing straining associated with severe constipation causes profound collateral damage over the years. We see complete rectal prolapse, where the sheer force of the intra-abdominal pressure causes the rectum to literally turn inside out and telescope entirely through the anal sphincter.
We see irreversible damage to the pudendal nerve and the pelvic floor musculature from decades of straining, leading to long-term fecal incontinence, even if the constipation is eventually resolved.
Right.
We see acute urinary retention due to the physical compression of the urethra by a massive, rock-hard impacted rectal mass. And we see fistula in ano resulting from chronic cryptoglandular infections driven by the constant mechanical trauma of hard stool tearing the anal mucosa.
This raises an incredibly important, almost philosophical question about surgical intervention. We have these incredibly powerful tools: total abdominal colectomies, STAR procedures, laparoscopic rectopexies, sacral nerve stimulators. But who is actually a candidate? If a patient is suffering, do we just operate?
This is perhaps the most critical caveat regarding surgical management, and the sources are absolutely definitive on this point. Rigorous patient selection is vital for a good outcome.
Vital.
A total colectomy in a patient who is psychologically addicted to laxatives, or one who refuses to implement lifestyle changes and continues to use a variety of over-the-counter laxatives despite a surgical intervention, well, that will result in universally poor outcomes.
Because at the end of the day, surgery fixes anatomical and transit failures. It repairs a prolapse or it removes a dead colon. It does not fix behavioral or psychological failures.
No, It doesn't.
If the underlying etiology is deeply rooted in psychosocial issues, severe anxiety disorders, or complex somatization, all of which are explicitly listed in the differential diagnosis for functional constipation, a scalpel will not cure them. In fact, for the significant number of people who become genuinely disabled because of chronic constipation, taking their colon might just replace one disability with another, far worse one, if the selection criteria aren't absolutely rigorous.
Precisely. The surgical treatment goal is always to produce symptom alleviation and restore dignity. But we must be mathematically certain, via our diagnostic workup, that we are treating the correct physiological disease and not just aggressively chasing a symptom in a poorly selected patient.
Okay, we have covered an immense challenging landscape today. We started by discarding the simple plumbing analogy and mapped the complex pathophysiology of normal transit, slow transit, and pelvic floor dysfunction. We explored how systemic diseases like Chagas or metabolic derangements like hypercalcemia basically paralyze the gut's engine.
We dissected the clinical evaluation, realizing that simply asking a patient if they are constipated is a huge diagnostic trap. We focused heavily on the alarm signs, bleeding, weight loss, and the ominous empty rectal vault in an obstructed patient.
Right.
We then walked through the advanced physiological toolkit, utilizing colonic manometry to track the electrical pulses, transit studies to follow the cargo, and defecography to witness the architecture failing under stress.
We bridged the gap with pharmacology, visualizing how drugs like lubiprostone act as chemical floodgates, while prucalopride attempts to jumpstart the enteric nervous system. And finally, we confronted the surgical realities from the nuclear option of a total abdominal colectomy to the targeted repair of a STAR procedure, all while guarding against the devastating complications of stercoral perforation and volvulus.
It is a demanding algorithmic approach that every advanced clinician must master to navigate the deeply complex, often murky waters of lower gastrointestinal pathology.
It absolutely is. And then that leaves us with a final forward-looking thought for you, the listener. We talked about sacral nerve stimulation, implanting electrodes to pace the pelvic floor. If neuromodulation can successfully, albeit sometimes temporarily, override the extrinsic neural control of the large bowel to treat refractory constipation, to what extent will the future of severe constipation management move away from the physical, brutal, irreversible resection of the colon and move entirely toward the pure electroneural hacking of the gut's nervous system?
It's an incredible thought.
Could the senior surgeon of the future treat profound colonic inertia entirely with microelectrodes and targeted neuromodulation rather than ever having to pick up a scalpel to perform a colectomy?
It is a profound question, and it really represents the bleeding edge of neurogastroenterology and surgical innovation.
Something to mull over before you scrub in for your next case. Thank you for joining us on this deep dive into the clinical evaluation and management of constipation. Keep pushing the boundaries, trust the physiology, and we will catch you on the next one.